Good afternoon. This is Pediatrics Center of Excellence in HIV Care, Medical College and Hospital, Kolkata. Welcome to today's RDLS session. Today's topic is common comorbidities in CLHIV. And today's speaker is Dr. Rajasree Sinha. She is currently working at Pediatric Department of Medical College as a senior resident. She has completed her Master MBBS from IPG MERNR and MD from Medical College and Hospital, Kolkata. I will now request ma'am to enlighten us on today's topic. Thank you very much.
Thank you for the introduction. Good afternoon, everyone. I'm Dr. Rajasree Sinha. I welcome you all to today's session on common comorbidities in children living with HIV. So in today's session, we are going to cover the following comorbidities. Firstly, malnutrition, anemia, thrombocytopenia, hepatic dysfunction, chronic respiratory morbidities, neurological morbidities, and few other comorbidities. At the time when a child is diagnosed with HIV, they may have a variety of clinical manifestations depending on their age and the severity of immunodeficiency. These manifestations may involve one or more systems, and that will influence the clinical staging of HIV, the regimen that is to be given to them, as well as the treatment for these conditions. This systemic involvement has a direct influence on the health status and mortality, and an indirect influence on the ART adherence due to various drug interaction and added pill burden. All the systems may be involved either directly by the HIV virus or secondarily to other OIs. Like a child may present with encephalopathy, which could be due to the HIV virus, or it could be due to cryptococcal meningitis or any other infective organism. So we have to keep these points in mind. The common comorbidities which we might find in a child with HIV at the time of diagnosis, system-wise, firstly, infective comorbidities like tuberculosis, various bacterial, fungal, viral infection, localized or disseminated. When it is a disseminated disease, we call it sepsis. Nutritional comorbidities like wasting, which is a low weight for height, stunting, which is a child who has very short stature, and other vitamin deficiencies. GI system involvement like recurrent or persistent diarrhea, meaning diarrhea for more than 2 weeks. The child may present with oral esophageal candidiasis, recurrent persistent oral ulcers. Hepatobiliary system involvement due to hepatitis B, C viruses, other organisms which might cause hepatitis. Hematological involvement like anemia, thrombocytopenia, which we will discuss in details later. CNS involvement like delayed development or developmental regression, like a child who was previously able to walk might suddenly find it difficult to do so. The child could present with meningitis due to various bacterial viral agents, including TB, cryptococcus, even HIV itself can cause encephalopathy. Respiratory system involvement like recurrent persistent pneumonia, bronchiectasis, sinusitis, chronic otitis media, lymphoid interstitial pneumonitis. And lastly, skin and soft tissue infections due to various bacteria, fungus, nutritional dermatosis, scabies, molluscum, herpes, neuritic papillary eruptions, organisms which normally will not cause infection in immunocompetent people will have a profound effect on a person with HIV. So firstly, we will start with malnutrition, which is extremely common in children living with HIV. In our country, even normal children, malnutrition is very common and more so in those with HIV. Infants and young children are more likely to present with wasting, that is, reduced weight for height. Older children who may have an intermediate disease progression are more likely to present with stunting, which is reduced height for age. Malnutrition is an important cause of mortality in CLHIV, especially in the developing world. Children who have mild or moderate malnutrition could be managed as an outpatient basis, but those with severe acute malnutrition will require admission and therapeutic feeding. To classify the nutritional status of a child from 0 to 5-year-old, we use the following anthropometric indices like weight for age, length or height for age. For children less than 2 years, we measure the length, and for more than 2 years, we measure the height. Nutritional status may be graded in 4 categories. The child could be normal nutritional status, could be underweight, could have wasting, or could have stunting. So the indicators, if the weight for age of the child is below -3 standard deviation, we classify them as severely underweight. If it is below -2 standard deviation, we classify them as moderately underweight. If it is between the median and 1 SD, we classify them as normal. Similarly, for the indices of height for length or height or length for age, we have a severely stunted when it is below -3 SD, we call it stunted. When it is below -2 SD, we call it normal. When it is below -1 SD. Also, weight or length for height, it is called severely wasted or severe acute malnutrition when it is below -3 SD. We call it moderate acute malnutrition when the weight for length or height is below -2 standard deviation. And when it is between median and 1 standard deviation, it is normal. We will discuss about this in details. So combined use of anthropometry and clinical parameters. When do we classify a child as severe acute malnutrition, and when do we say the child has moderate malnutrition? For a child to be classified as severe acute malnutrition, we will need any one of the following 4 parameters. If the weight for height is less than -3 SD, and or the child has visible severe wasting, and or the mid upper arm circumference is below 11.5 centimeter, and or the child has edema of both feet. A child who has any one of these 4 will classify as a child with SAM. When is it moderate malnutrition? If the weight for height is between -2 SD and -3 SD, and or the mid upper arm circumference is between 11.5 to 12.5, the child has moderate malnutrition, and of course the child should not have any edema and no severe wasting. So this is a WHO chart where we can plot the weight and the length or height of the child, and we can see whether the child falls in which category. As we can see here, the length there is a separate chart for girls and a separate chart for boys. So we have to use a sex-specific chart. Firstly, we will plot the length of the child, the center white column, which is in centimeter, it is given here. Once we know the length of or height of the child, then we will move on to the weight of the child. If the length is somewhere in between 2 values, like it is 64.3. So if it is below 0.5, we will round up to the value above. Like if it is 64.3, we will take it as 64. And if it is more than 0.5, then we will round off to the value below. Like if it is 64.6 maybe, then we will take the height as 65. So we plot the height or length, and then we move sideways to the weight of the child. So here we can see it is given as green, yellow, and red. If the weight falls in the red zone, we will say it is below -3 SD and the child has severe acute malnutrition. If it falls in the yellow zone, then it is moderate acute malnutrition. And if it falls in the green zone, that is normal nutrition. There is no malnutrition. So here it is described how we can use that chart. We can also use the WHO charts where there are various curves relating to the standard deviation score. We can plot the weight, we can plot the height and the weight of the child in that chart, and also find the nutritional status. Next, coming to measuring the mid upper arm circumference. For measuring the mid upper arm circumference, we have this color coded tape, which is called the Shakir's tape. Here, first we have to locate the tip of the shoulder or the acromion process. We can see in the diagram how it is palpated and located. Next, we have to locate the tip of the elbow joint. Then we have to use a tape. We will place a tip of shoulder and we will pull the tape past the tip of bent elbow. And then we will mark the midpoint. Across the midpoint, next we will pass the tape, which has a slit or window through which it could pass. And then we should snugly fit it on the arm. Here, what has to be kept in mind is the tape should not be too tight. That is, the elbow here, as is seen in the picture number 8, it is compressed. This should not happen, nor should it be too loose. Like in picture number 9, where we can see there is some space between the arm and the tape. So picture number 10, here it is demonstrated the correct tape position. It should not be too tight. It should not be too loose. It should just snugly fit the mid-upper arm. So here the value of the mid-upper arm circumference can lie either on the green zone, which is normal nutrition. It can lie on the yellow zone, which correlates to 11.5 to 12.5 centimeter, which signifies moderate acute malnutrition. But if it lies in the red zone, that is the MUSC is less than 11.5 centimeter, we will classify the child as severe acute malnutrition. So here it is given another, again, what I have just said. If it is the green zone, well-nourished child, MUSC is more than 12.5. If it is yellow, it is moderate acute malnutrition, MUSC between 11.5 to 12.4. And less than 11.5, we have the red zone or the severe acute malnutrition. Next indices is how to check for wasting or severe wasting. We have to look at the child from the front first and decide, is the outline of the child's ribs easily visible? Does the skin of the upper arms look loose? Does the skin of the thighs look loose? As in the picture, we can see the ribs are very easily visible. We can count all the ribs. The upper arm skin is hanging and loose, and the thigh skin of the thigh, those are loose too, and we can see skin folds. So this is visible wasting or severe wasting. Next, we have to look at the back of the child and decide. Again, are the ribs, shoulder bones, and spine easily seen? Is there any wasting seen on buttocks? As seen in the picture, we can see again the ribs and spine are easily visible, and the skin of the buttocks, they are hanging loose. So this is severe wasting. Next is checking for bilateral pitting edema. Edema in malnutrition is due to hypoproteinemia, could be due to superadded infection also. So the edema in SAM starts from the dependent part, that is the feet in a mobile child. As the severity of edema will increase, it will extend to the leg and then move up to cause swelling of even upper limb, face, abdomen, or anasarca. To check for edema, what we have to do, we have to grasp both feet so that the rest in our hand with one thumb on top of each foot and press gently for a few seconds, approximately 10 seconds. As demonstrated in the picture, the child has bilateral pitting edema if pit or dents remain in both feet when we lift up our thumbs. As can be seen in the picture, in the first one, we are pressing the feet with both our hands, with the feet resting on the hand. And then after releasing the pressure, we can see the indentation persisting. So the child has pitting edema. So that is how we diagnose moderate acute or severe acute malnutrition. Next, coming to the management of a child with moderate acute malnutrition. We have to first assess for their feeding practices and underlying medical conditions. We have to counsel the mother or caregiver so that they can give feeds in adequate amount, frequency, and also the quality of feed, which has to have adequate energy density and should be hygienic. We should counsel for food diversity and active feeding, and obviously follow up after 15 days to check for weight gain. Any underlying medical condition, if identified, like cleft palate or a congenital heart disease, infection, etc., which can cause weight loss, they should be treated first, and also the child should be referred to a higher center. If no underlying medical conditions are identified, we should counsel mothers for giving appropriate feed for the age. The counseling of the parents and motivating them to feed their child proper hygienic food in adequate amount is very important. So management of severe acute malnutrition in a very short, if we summarize it in one box, we can say if there is any independent or additional criteria, if the child has no appetite, and if the child has associated medical complications, then the child should be managed in a facility and should not be allowed to go home. Firstly, we should start with the F75 diet. What is an F75 diet? It is a diet in which each 100 ml of the food will have 75 kilocalories and around 0.9 gram protein. In a child with severe acute malnutrition, if initially we start feeding with high protein and sodium in the diet, the child might even die because their metabolism will not able to handle that amount of protein and sodium. So we have to start cautiously with an F75 diet, and as after 2 to 3 days, the child responds to that and tolerates that, we move on to F100 diet, which is a little bit more calorie dense, where each 100 ml will have 100 kilocalories and the protein will be 2.9 grams. So we can give the F100, or we can use ready-to-use therapeutic food and 24-hour medical care. What is the discharge criteria after the child has been fed and the child is tolerating the feed? And we have seen that the edema has reduced, the child has good appetite with acceptable intake of RUTF, and there is weight gain. We can discharge the child for community-based care. If in the beginning we find the SAM child to have a good appetite and there is no medical complication, we can manage the SAM child in the community also with ready-to-use therapeutic food and basic medical care, but we have to obviously monitor for weight gain. So what are the indications for hospital management in severe acute malnutrition? If the child has any emergency sign, if the child has hypothermia, meaning axillary temperature less than 35 degrees centigrade, if there is edema, if there is persistent vomiting so that the child is unable to have a proper intake of food, if the child is very weak and apathetic, if the child has fever, axillary temperature more than 39 degrees centigrade, if the child has fast breathing and chest indrawing, signifying that the child has pneumonia, if there is extensive skin lesion and eye lesion, if the child has diarrhea with dehydration, if the child has severe anemia, if the child has purpura or bleeding tendency, if the child has evidence of systemic infections or complications, if the child has any clinical sign of secondary cause of severe acute malnutrition. In all these cases, we cannot leave the child in the community. We should admit the child and give them a facility-based care. So that is all about malnutrition. A child with HIV who presents with malnutrition and a child who do not have HIV and presents with malnutrition, the management of the malnutrition part is similar. But we have to keep in mind that CLHIV patients are more prone to malnutrition. So the next comorbidity that we are going to discuss is anemia and thrombocytopenia. What is anemia? Anemia is a condition in which the number of red blood cells is insufficient to meet the body's physiological need. We have age-based cutoff of hemoglobin level to classify the anemia as severe anemia and only anemia. For a child between 6 months to 5 years, if the hemoglobin is less than 7, it is severe anemia. And if it is less than 11, it is anemia. For a child of 5 to 11 years, if the hemoglobin is less than 11.5, the child is said to have anemia, and if it is less than 8, it is severe anemia. Similarly, for a child more than 12 years, if the hemoglobin is less than 12, the child is said to have anemia, and if it is less than 8, the child has severe anemia. Anemia is present in a large proportion of CLHIV at presentation, and the most important cause are chronic disease and nutritional deficiencies. In a patient who is already on ART with rapid development of anemia, we should suspect drug toxicity like zidovudine-induced marrow suppression as a likely cause. So what are the causes of anemia in CLHIV? One could be decreased production, or it could be due to increased loss or destruction. Decreased production can have various causes. Firstly, the deficiencies like iron deficiency, vitamin B12, folate deficiency. Infection is also a major cause. Malaria, Kala-Azar, HIV itself, CMV, Epstein-Barr virus, parvovirus, TB, MSC, histoplasma, all these could cause anemia. Various drugs, children who are already on ART with zidovudine, cotrimoxazole, ampho-B, these drugs also cause marrow suppression and anemia. Anemia of chronic disease, which are frequent OIs in children with HIV, could also be a cause. And lastly, malignancies like lymphoreticular malignancy, Hodgkin's disease, all those will cause marrow suppression and anemia. Anemia could also be due to increased loss or destruction, as in hemolysis, which could be autoimmune, or any pre-existing condition in a child like thalassemia. Thalassemic patients, they receive such frequent blood transfusions and they are prone to HIV, so they will also present with anemia. GI bleeding could be a cause with various infections like CMV, Candida, parasites, bowel lymphoma. And lastly, hypersplenism, which will also cause anemia due to increased loss or destruction. So when a child with CLHIV presents with anemia, we have to take a thorough history. The child will usually present with easy fatigability, irritability. The child will have decreased food intake or anorexia. The child could present with pica, that is the habit of eating non-nutritional substances like mud, hair, chalk, pencil, anything. The child will look pale. The child will have poor school performance. The child could present with dyspnea on exertion, palpitation, dizziness, signifying an underlying heart failure. The child could also present with headache. We need to elicit the following history of blood loss. Is there any epistaxis or nosebleed? Is there any melena or blood in stool? Is there any perrectal bleeding due to an anal fissure? Is there excessive menstrual losses in adolescent girl? Does the child have chronic diarrhea? Does the child have recurrent jaundice, signifying an underlying hemolytic process? We have to take a drug intake history of anticonvulsants, zidovudine, cotrimoxazole, which could all cause anemia. History of repeated blood transfusion, any bleeding disorder, thalassemia. Past history, we have to ask for chronic infection, liver renal disease, any history of hospitalization, any significant past history should be elicited. Next comes the family history. Severe anemia in the family requiring frequent blood transfusion, as in thalassemia patients. Any history of bleeding disorder in family, like in hemophiliacs, they might have an uncle or somebody with a bleeding disorder, which could also lead to anemia. Recurrent jaundice or gallstone usually indicates a hemolytic anemia. Next, we have to ask about the diet of the child. Most common cause of anemia in children is nutritional anemia, be it HIV or non-HIV. The type of milk given after birth and age at which complementary foods were introduced, we have to ask. A child who had a faulty weaning process will have anemia. If there is excessive intake of milk with reduced intake of other food groups, the child will have anemia. History of pica, we have to ask, which increases the risk of helminthic infection and cause a chronic GI blood loss. That may also present with anemia. After history, we have to examine the child. A general head-to-toe examination is essential to look for signs of anemia. Any vitamin deficiencies? Is there any lymph node enlargement? Is there splenomegaly? Is there signs of congestive heart failure? Pallor can be assessed by comparing the child's palm with our own to judge the severity of anemia. We can look for pallor by comparing the palm. We can look for pallor by seeing the lower palpebra. We can look at the tongue. We have to see for presence of jaundice, which will indicate the possibility of hemolytic anemia. We have to look for tachypnea, tachycardia, hepatomegaly, which may indicate congestive heart failure that may accompany severe anemia. Any petechial rash, any lymphadenopathy, any organomegaly will point to an underlying lymphoreticular malignancy. We have to check for angular stomatitis, glossitis, colonukia, and signs of vitamin deficiency, which might also be present. So after thoroughly examining the child, we move on to investigation. Complete blood count, firstly, which will give us the hemoglobin value to confirm the diagnosis of anemia and its severity. Next, we have to look at the peripheral blood smear. Does the child have microcytic anemia, which is usually due to iron deficiency, but thalassemia is also an important differential diagnosis. Macrocytic anemia, meaning the red cell volume is increased more than 100 FL. That is likely due to vitamin B12 and folic acid deficiency. Or is the anemia normocytic, normochromic? That is, the red cell indices are normal, but the hemoglobin is low, which is more often seen in anemia of chronic infection and acute blood loss. Or is it a pancytopenia, meaning all the three cell lines, platelets, the total count, lymphocytes, and hemoglobin, all three cell lines are affected, which would signify a more grave disorder like aplastic anemia or lymphoreticular malignancies. So a CBC with PBS will give us a fair idea of the type of anemia and cause to some extent. Next, we have to look at the reticulocyte count. Is it increased? Is it low? Or is it normal? An increased reticulocyte count will signify ongoing hemolysis or non-chronic blood loss, in which the marrow tries to compensate by increasing production of hemoglobin, of red blood cells. Or is the reticulocyte count low? In spite of having a low hemoglobin, if the retic count is low, that will signify bone marrow depletion. So after investigating the child, we move on to the management of anemia. Management is under 3 prongs. Firstly, deworming the child. All CLHIV needs to be dewormed once in 6 months. This is true for all children, irrespective of HIV status. We administer albendazole tablet or syrup, 200 mg single dose for children up to 2 years of age. And for those beyond 2 years of age, we use an adult dose of 400 mg. And we repeat albendazole every 6 months. Next is supplementing with iron and folic acid. Supplement with oral iron at a dose of 3 to 6 milligram per kg per day of elemental iron. And iron should be given in empty stomach. To enhance the absorption of iron, it should be given in between meals. No milk or milk products should be given along with it. Anemia usually gets corrected over 2 to 3 months of treatment, but we have to continue the oral iron supplementation for another 2 to 3 months to build up our stores. Folic acid at a dose of 100 to 200 mcg per day is adequate to treat associated folic acid deficiency. Nutritional counseling, which is very important. We have to counsel the caregiver mother to give iron-rich food items such as green vegetable, peanuts, jaggery, eggs, chicken, etc. We have to stress that milk and milk products are poor source of iron and excessive milk might cause harm. When do we refer an anemic child for pediatric evaluation? Those with severe anemia without signs of congestive heart failure, like tachypnea, tachycardia, enlarged liver, respiratory distress. If all those symptoms are present along with anemia, we have to refer the child. Those with megaloblastic anemia or pancytopenia, those need to be referred. Those with clinical features suggestive of hemolytic anemia, meaning the child has jaundice, the child presents with a gallstone along with anemia, along with jaundice, we have to refer. Or if there is a suspicion of a lymphoreticular malignancy, like the child has pancytopenia, organomegaly, lymphadenopathy in such cases. And lastly, those who are not responding to oral iron supplementation, those child also we need to refer. Next comorbidity is thrombocytopenia. What is thrombocytopenia? That is a platelet count which is less than 1 lakh. It is commonly encountered in CLHIV and it also may be an initial manifestation of HIV infection. Various etiologies include immune-mediated platelet destruction. It could be TTP. It could be due to impaired hematopoiesis due to bone marrow suppression. So bone marrow studies are needed for evaluation of cause. Management is same as in children without HIV. Once causes like malignancy and aplastic anemia are ruled out by bone marrow biopsy, most CLHIV with mild thrombocytopenia, which are due to the HIV virus, will respond to ART itself. But all children with thrombocytopenia need to be referred to a pediatrician for thorough evaluation. So moving on to the next comorbidity, that is hepatic dysfunction in CLHIV patients. Causes of hepatic dysfunction. Hepatomegaly and mildly elevated liver enzymes are common in CLHIV, though chronic progressive liver disease is unusual. The most likely causes are co-infection with viruses like A, hepatitis A, B, C, E, CMV virus, Epstein-Barr virus, co-infection with MSC, cryptosporidium, fatty liver, drugs toxicity, all could cause a hepatic dysfunction. So again, we have to start from history. Is there a history of jaundice, anorexia, nausea, vomiting, fever, right hypochondriac pain, pruritus, pale colored stool? Next, examination of the child for icterus. We have to look for hepatomegaly. How much is it enlarged? In infants, normally 2 centimeter liver is normal. And in children up to 5 years, around 1 centimeter, the liver is normally enlarged. So we have to measure the enlarged liver. How much has it increased in size? We have to measure the liver span. Has it increased? Has it decreased? We have to look for the sensorium of the child. Whether the child is irritable. Does the child have an altered sleep pattern? Is he feeding, not feeding well? Is there ascites? Is there bleeding manifestation? To look for early signs of acute liver failure and hepatic encephalopathy. So the investigations indicated in evaluation of a child with hepatitis. Firstly, we will do a liver function test, which includes total and direct serum bilirubin, the liver enzymes ALT, AST. ALT and AST are usually elevated We should also look at the peripheral blood smear to look for malarial parasite, which is a common cause. We have to test for the hepatitis viruses like HBsAg, HCV, HIV test. We have to check the blood glucose. We have to check the coagulation profile, the prothrombin time. We have to look whether the electrolytes are in normal range. The presence of jaundice is indicative of an acute hepatitis. It is essential to gauge the severity of the dysfunction, that is there hepatic encephalopathy and coagulopathy. So coming to the treatment, it is mostly supportive. We have to remove the potentially offending medication as per the ARV adverse event guidelines. If the child is on anti-tubercular therapy, institution of modified AT regime, we have to give supportive care like monitor vitals, hemodynamics, nutrition, rest. And if the child progresses to hepatic failure and encephalopathy, we have to monitor the child very meticulously, preferably in an ICU setup. We have to do intestinal contamination. We have to give lactulose, bleomycin, modified diet with reduced protein intake. We have to treat the coagulopathy with vitamin K, fresh frozen plasma. We have to treat any associated infection very aggressively with antibiotics, correct any dyslipidemia, give antacids H2 blocker, oxygen, ventilation, depending on the status of the child. Presence of hepatitis and its severity and etiology influence the initiation of ART as well as the drug regimen. Many antiretroviral drugs, especially nevirapine and protease inhibitors, have associated hepatotoxicity. So we have to eliminate those drugs from the ART regimen. Coming to the next comorbidity, which is chronic respiratory morbidity in CLHIV. Firstly, we will talk about bronchiectasis. What is bronchiectasis? It is a disease characterized by irreversible abnormal dilatation of the bronchial tree. When a child with CLHIV has bronchiectasis, it is classified as WHO stage 3 disease. The child will present with persistent cough and fever with productive purulent sputum or hemoptysis, and that should arouse the suspicion from bronchiectasis. Clubbing or swelling of the fingertips might also be present. We have to examine the chest, which will reveal localizing sign and not easily resolve with usual antibiotic treatment. Chest X-ray will show cystic spaces, occasionally with air fluid levels and honeycombing. Management includes that of acute exacerbation has to be treated with adequate antibiotic therapy, and that too for a prolonged period of minimum 2 to 4 weeks. Postural drainage of sputum. Antibiotics should be carefully chosen to cover a broad spectrum of microorganisms, including gram-negative bacteria. Every attempt should be made to isolate the organism by sputum culture or induced sputum or secretion obtained through bronchoscopy and bronchoalveolar lavage. The treatment involves, again, administration of antibiotics during acute exacerbation and bronchodilators. Surgical treatment may also be necessary if the symptoms are severe or refractory to medical management and the disease is limited to one segment or a lobe. Next, coming to lymphocytic interstitial pneumonia or LIP. This is also a stage 3 clinical condition. It is a lymphoproliferative disorder, and this is not an infective pulmonary disorder. It is characterized by diffuse infiltration of CD4 lymphocytes, plasma cells, histiocytes in the alveolar septa and along the lymphatics. Mostly children who are more than 2 to 3 years with HIV present with this. The disease has an insidious onset of mild but persistent cough with or without exertional dyspnea and breathing difficulty, and there may be associated clubbing. LIP should be suspected if a child does not respond or if chest X-ray findings persist or worsen despite appropriate antibacterial and antituberculosis treatment. Treatment of LIP includes bronchodilators and corticosteroids, short course for mild intermittent symptoms, and long course with slow taper in chronic cases. So in bronchiectasis, that was an infective cause. LIP, here it is a lymphoproliferative disorder, and we have to keep this in mind. So while evaluating a HIV-infected child with respiratory symptoms, it should be remembered that the patient may be having more than one clinical entity responsible for his or her symptoms. It is not infrequent for a patient to have TB and bronchiectasis, or TB and LIP, or LIP and bronchiectasis. So due to this overlap of disease and symptoms, we have to keep an open mind and we have to investigate the child for all possible causes of the symptoms. Next, we come to the neurological morbidities in CLHIV. So the pathogenesis of neurological illness in HIV. HIV enters the brain through infected monocytes and T lymphocytes that will cross the blood-brain barrier. Direct invasion of nerves by the virus causes inflammation, degeneration, disruption of neurotransmission, vasculopathy, and demyelination. In children, all these changes occur in an immature brain, hence morbidity is more severe as compared to adults. So what are the risk factors for neurological involvement in HIV in children? The route of transmission, higher risk of neurological morbidities in children with perinatal transmission. Severe immunosuppression in child results in a high plasma viral load in blood and CSF. The age of the child. Highest incidence of HIV-related CNS manifestation occurs in the first 2 years of life, with incidence rates of 9.9% in first year, 4.2% in second, and less than 1% in the third year of life and thereafter. Presence of other comorbidities like prematurity, low birth weight, poor nutritional status, these increase the risk for neurological involvement in HIV in children. So what is the spectrum of primary neurological manifestation? The child could have a HIV-associated encephalopathy, could present with stroke syndromes, could also present with HIV-associated neurocognitive disorders, which can vary in severity from asymptomatic neurocognitive impairment to severe dementia. So the general principles for management of neurological morbidity. CNS involvement in CLHIV can be very subtle. So we have to carefully assess the neurodevelopment and look for red alerts in HIV-infected children, especially infants and toddlers. We have to follow a syndromic approach to identify etiology. Neuroimaging can be useful. Early detection of HIV infection through systemic follow-up and evaluation of HIV-exposed infants, and timely ART initiation is the key to mitigate CNS insult. So early diagnosis and early treatment initiation in an infant or in a child born to HIV mother who has HIV will help in preventing this HIV-associated CNS insults. And also effective ART can prevent and to some extent reverse neurological signs and symptoms. So the neurological manifestations in CLHIV, children less than 5 years will have global delay in achieving milestone, motor and cognitive. They can also present with static or regression of milestone. They will have microcephaly, that is the head circumference less than 3 standard deviation. The child could present with progressive spastic paralysis or could present with various pyramidal tract signs like ataxia, seizures, and such. In older children, they usually present with progression or regression of learning milestones. They will have attention difficulties, poor school performances. They will have impaired cognitive function. They will have difficulty in conversation, in comprehension, in perception, and various motor activities. HIV encephalopathy, which is the most common CNS manifestation of pediatric AIDS. It can occur in the first few months of life and may precede sign of immune deficiency and other systemic manifestation of HIV disease. It is diagnosed if a child with HIV have any one of the following signs for 2 months in the absence of demonstrable causative organism. Number 1, failure to attain or loss of developmental milestone or loss of intellectual ability. Number 2, progressive impaired brain growth demonstrated by stagnation of head circumference. Number 3, acquired symmetric motor deficit manifested by any 2 of the following signs: paresis, exaggerated reflexes, ataxia, or gait disturbances. So any one of the following 3 for more than 2 months in the absence of a causative organism will signify the child to have HIV encephalopathy. CT of brain may show cortical atrophy and bilateral basal ganglia calcification. MRI will show the presence of cerebral atrophy, cerebellar atrophy, calcification in basal ganglia, and signs of attenuation of white matter. HIV encephalopathy, even when arrested by ART, will leave residual cognitive and motor deficits with significant impact on independent mobility and daily living. So frequent association with lack of nurturing, a poor social environment, and parental sickness, all these contribute towards overall poor development of these children. Thus, poor school performance, dropping out of school, and a very poor quality of life is common in these children. Coming to the management, all HIV exposed and infected children must undergo routine development assessment at presentation and during follow-up visit to identify any regression of milestones or any delay in attaining a milestone. A detailed evaluation is needed for children with developmental delay who have poor school performance or behavioral issue, and they all will need to be referred to a pediatrician and psychologist as appropriate. So early detection and management is the key, and also early initiation of ART. A few other comorbidities which a CLHIV patient can present with: cardiomyopathy. All components of the cardiovascular system might be affected during the course of HIV. It is likely that HIV-related cardiac disease has a multifactorial origin due to the virus itself, due to various secondary infections, other concurrent disease states, side effect of therapy, nutritional deficiency, and yet unknown factors. Dilated cardiomyopathy is the most common cardiac complication of HIV in children and is an adverse prognostic indicator in patients with HIV. DCM, the only treatment option is heart transplant. So it's a very, very adverse prognostic indicator. Zidovudine has been implicated in the etiology of cardiomyopathy, so its role has not been established firmly. CLHIV on zidovudine-based ART regime should be monitored clinically for evidence of cardiac disease. Early atherosclerosis may be a new emerging disease in HIV-infected children. Next is pulmonary artery hypertension. PAH, it is also a very serious disease of the pulmonary arteries and is characterized by an increase in pulmonary vascular resistance and pulmonary arterial pressure. Pulmonary artery hypertension is defined when a resting mean pulmonary artery pressure exceeds 25 millimeter of mercury, or mean pulmonary artery pressure following exercise exceeds 30 millimeter of mercury. The child with PAH will usually present with exertional breathlessness due to inability of the right ventricle to raise cardiac output with exercise. Other symptoms they might have are hemoptysis, chest pain, congestive heart failure, dizziness, syncope, and arrhythmias. Chest X-ray in PAH may show cardiomegaly and pulmonary artery enlargement. ECG is usually diagnostic, which will show right axis deviation, right ventricular hypertrophy with right axis deviation. HIV-associated PAH is confirmed only after all other possible causes of PAH have been ruled out. Hence, all children with signs suggestive of PAH need an urgent referral to a pediatrician. So that is all. Thank you.
Thank you. Or any questions from the participants? Ma'am, I don't think there are any questions. Thank you so much for facilitating this session.
Thank you.
Thank you. We'll conclude the session now. Thank you.
Okay. Thank you. Thank you.